My name's Rachel Hnatowich. I'm a child psychiatrist at Children's Hospital, and I work in medical psychiatry. So I see kids that are here in the hospital for medical reasons, providing support around that. The topic was around mental health. Most I'm going to be talking about is anxiety. It's kind of what I see most of the time, but I am going to go a little more into like trauma and depression as well. So just kind of starting about like pediatric anxiety. Anxiety is normal. So anxiety is a normal, automatic response to dangerous situations, either perceived or real. It can be adaptive when it facilitates avoidance of danger, and it can also be developmentally appropriate. So, again, anxiety as its own, not a bad thing. It's a good thing we have it. It helps us survive situations. But it becomes pathologic when there's persisting levels of anxiety, distress, avoidance, or functional limitation. Anxiety disorders in childhood are really, really common. Prevalence between 10 and 20%. And these are old numbers. I really had a hard time getting a more recent number of what prevalence is. I know that it's thought to have doubled in the last decade, and that was even pre-COVID. So I think that what we know is there's a lot of anxiety in our kids all over. And anxiety disorders in childhood do predict further mental health issues in adolescence and adulthood. So it's good to kind of try to get a handle on them as early as we can. So, but generally, anxiety across the years, again, anxiety presents in age appropriate ways. So how one kid looks anxious will be different based on how old they are. So again, it can be normal at each stage, but it may develop into an anxiety disorders if they persist or they're exaggerated beyond the normal developmental trend. So for example, between ages 1 and 3, you'll see more stranger anxiety and separation anxiety. And this makes sense. Once an infant is able to recognize like the parent is a different person than me, they need their parents to survive. If not, they're going to die, they're going to be taken. So it's important to have the parent close by. And so that's how it's important to have separation anxiety. Mom, don't go away, or someone's something that's you're not going to feed me, or a stranger, get away from me, you could take me away. So they're normal. But then as the kid develops the cognitive capacity to start thinking about future events, it shifts. And then you start seeing more of like fear of lightning, thunder, animals. As the kid starts to develop more imagination, there may be fear of monsters, imaginary people, people dying, particularly this is often the age where a grandparent may die. And then as they get a bit older still, then there's more fear of specific situations. So like fear of making mistakes. What if I don't fit in? Fear of natural disasters. I've heard a lot of kids worried about bombs being dropped after the Ukraine war, for your school performance, friendships, and then kind of more closer to adolescence, that fear of social judgment, of social competence health issues. So there are quite a few challenges though about identifying anxiety in kids is that anxiety can be normal or pathologic depending on the age and the context. So for example, again, separation anxiety in a 3-year-old is relatively normal. Separation anxiety in a 12-year-old is less normal. But if you have someone who's 12, but cognitively they're closer to 6 or 5, it still may be normal. So understanding the context and the age is important. Kids often lack the cognitive ability to talk about their worries or thoughts. They're just not really great at telling you what's going on. Very few are going to tell you, I'm really worried about this or this or this. It's just going to come up more in behaviors. And so the assessment often needs to include multiple sources beyond the child. So again, anxious kids may not look anxious, and it often presents as a huge host of other symptoms, including crying, freezing, withdrawal, indecisiveness, being clingy, having big temper tantrums, irritable, rage attacks, defiance, refusing to engage in tasks, or big emotional dysregulation. You can also see a lot of hypervigilance, emotional reactivity to situations they misinterpret as threatening. And so a lot of times parents will be like, I don't know what happened. We just asked something and they blew. But to the kids, something about that situation may have seemed threatening, even though to the adults there was no danger. And so then they cope through either avoidance, they shut down, don't make me, I'm not going to, or catastrophic emotional reactions, screaming, crying, throwing things. There can be a lot of excessive need for reassurance and what I call the what if questions. So, like, what's going to happen? Tell me all the information. I need to know everything was going to happen before. And that can be exhausting for parents to have to answer. And physical complaints are very common. So, a lot of kids may not say, I'm anxious, but they may say, my tummy hurts, my head hurts, things like that. And again, symptoms are often misunderstood as oppositionality and defiance rather than and avoidance. And so they can go diagnostically missed, and sometimes it will be identified as having an oppositional disorder, ADHD, when really it's anxiety. So, when you're thinking about anxiety, it's really complicated to understand anxiety. And so, when we're kind of trying to understand why a kid's anxious, I like to look at like all the factors that could be underlining it. So, I want to kind of get into it because it's so many things that lead to anxiety. So, we often think of what are the biologic factors or the factors kids are born with, the psychological factors, and then the social and environmental factors that could be contributing. So from the biologic factors, there's many things. So first is temperament. Some of us were just born with a certain personality and temperament that's hardwired. And a specific temperament called behaviorally inhibited temperament does place kids a bit at higher risk for anxiety. And these are the kids that are just naturally cautious. They're checking things out, they're observant, they're not going to jump into things right away. It's a great temperament to have, but it does mean they're more likely to be anxious. When kids have skills deficits, so if they had ADHD or learning disabilities or speech delays, things like that, where it's a bit harder to navigate the world, expectations may be a bit greater than their capacity to meet, are more likely to become anxious. In utero environment, I'm going to talk a bit more about this later, but we're learning more and more that the stress level that a mother experienced when the child was in utero can lead to higher risk and anxiety in the kid themselves. Family history, so genetics, just like any other medical condition, mental health conditions like anxiety and depression are somewhat genetically driven as well. And so our family history is important. Medical conditions, and not just in cardiac conditions, many medical conditions place a kid at a higher risk of having mental health issues. Early home environment, so if there's been a lot of traumatic events or changes or disruptive, situations, medical trauma, which is a big one we'll talk a bit more about, all those hardwire the brain to become anxious. And then having a hyperaroused nervous system. Some kids are just born with the nervous system on fire. These are the kids that were colicky when they were younger. They couldn't be soothed. You couldn't put them down. These are kids that have fast emotions. They happen really quickly. They are go on for a long time and they're slow to come down. And so all of this, the biologic factors are hardwired brain-based factors that contribute to anxiety later on. But then there's also the psychologic factors. So some will be personality traits. So kids, for example, that are high in perfectionism, high for desire to please, they don't want to disappoint people, they want to do things right. Again, super cool kids, but are a bit higher at risk of having anxiety. Internalizers. So when we think about kids, we generally separate them to internalizers, who again, the kids that keep their feelings to themselves, or the externalizers, the kids that like it's your fault, they blame other people, they act out. And usually the internalizers are the ones that are more at a higher risk of developing anxiety or depression. Their coping strategies are an important part of that. And so some kids are active copers. They're like, okay, what can I do about this? I'm going to figure it out. But some kids are more passive copers, which is this is too much for me. I don't have the agency to change. So they're going to cope through things like distracting or sleeping or shutting down. Those kids are at a higher risk of having anxiety. And then just simply having poor distress tolerance skills. Like the world is a distressing place, and a lot of us struggle to have the skills to cope with it or to change it. But if we're missing those distress tolerance skills, understandably, the world's going to be more anxiety provoking. Um, and then obviously in the social environments of childhood adversity, danger events where something happened that was traumatizing that can trigger more anxiety, and then parenting styles. And it's important to bring this up because this is something on anxiety, and so how we parent does contribute in some ways to our kids' anxiety levels as well. So generally, parents that are a bit more overprotective, and when you're parenting medical kids, you have to be more overprotective. Like there's so many more things you have to think about and protect them from, and so, but that when we're overprotective, we take away our kids' ability to kind of try things and make mistakes, and that can lead to more anxiety. Sometimes when parents are a bit more over intrusive or harsh discipline, basically when parents kind of retain control over problem solving tasks and the kids will develop their chance to develop things and promote autonomy, that generally can lead to more anxiety. And then parental accommodations. This is when parents will kind of allow their kids to avoid anxiety that can reinforce anxiety by engaging in rescue behaviors. And I thought I would tell a story from my own life just because sometimes it can feel like judgy when you talk about this. But um, my parents, lovely, lovely parents, but definitely their philosophy was like, if you're anxious, don't do it. And so I remember one time I was 17, I was in Boston. I just got my driver's permit. I was all proud of myself. The car was parked in a parking lot far away. I said, "I'll go get it on my own. I can handle this." Picked up the car, somehow find myself on I-95, which is the equivalent of Deerfoot. This is before, like, cell phones, before GPS. I was freaking out. I was awful. I wound up, like, reversing in an exit lane, like, everything you should never do. And so when I got back to the car, I was like, "Never again." And my parents' response was like, "Of course, we totally understand. We'll drive you everywhere. That was really difficult." And so they drove me everywhere. And I went to school in New York and I came back and they picked me up and they drove me everywhere. And And started becoming a bigger deal because now I'm 24 and I can't drive, and now I'm 25 and I can't drive, and driving has become this really big, scary thing. It's affecting my social life. I can't do stuff, and they just kept driving me and driving me and driving me. And it wasn't until I got married to a farm boy from Edmonton who was like, "This is stupid, and you're going to drive." And so he basically said, "We're getting on the highway. You're driving till we hit the border in Montreal. You're not stopping." And of course, it was awful, and I cried and I screamed, and I was convinced that like we're going to die, but now I can drive. And and the thing was that that anxiety, if my parents had just at that moment in time said, "This is really difficult, it's so scary, and tomorrow we're gonna start driving again because you have the skills and you can do this," I think it would've been very different, but it came from the love of their heart, like, but it only made my anxiety worse, and I think my point is not doing the things that make you anxious never, ever, ever make anxiety better. It makes you feel better in the moment, but it only makes anxiety worse in the long run. Okay, but specifically now let's get to the cardiac population. So anxiety is there, it's huge, it's normal, but mental health in the cardiac population is more complex. So there is a higher prevalence of emotional, behavioral, and social difficulties compared to their peers. So lifetime prevalence of depression and anxiety is around 50 to 65% in some research studies. There's elevated rates of internalizing disorders. Those would be the anxiety, depression, and externalizing disorders. In infants and younger kids, there's a higher risk of severe stress and trauma reactions. In mid-childhood and adolescence, there's a higher risk of neurodevelopmental conditions like autism, ADHD, and anxiety disorders. And what also makes it complicated is physical symptoms of anxiety and cardiac situations overlap, right? So it's harder to dismiss something like palpitations as anxiety when there's a cardiac history. You kind of have to work it up. But in anxiety, if the heart issues are in the context of anxiety, focusing on it makes it actually worse. So you're kind of in a situation you have to focus on physical symptoms, but sometimes that fuels the anxiety. And so all this leads to more hypervigilance and autonomic hyperarousal, which in turn is expressed through more physical symptoms and more anxiety. And so why is this would this be that, kids with these congenital heart issues are at a higher risk of mental health issues? And so there's biologic factors and psychological factors. So think about the biologic factors. One is lack of oxygen, right? So hypoxia. So a lot of these kids may have had decreased oxygenation in utero due to their altered, fetal circulation. They've had some of them had cardiac arrest, they've had surgeries, or maybe their oxygen has dropped low. That's led to some altered brain development, cognitive delays, deficits in executive functioning. And that's basically the functioning of our brain that thinks about the future and helps us plan. Um, there can be underlying genetic factors. So many of the congenital heart, disorders are related to genetic syndromes that are also associated with neurodevelopmental delay, like impaired cognition, autism, or psychiatric symptoms like anxiety, psychosis. So it's not to say that the heart issues have led to the mental health, but they're both related to the same genetic problem. There can be failure to thrive and low birth weight in these conditions, which can lead to nutritional deficits, and that can also affect cognitive development, which in turn places you at higher risk of these comorbid mental health issues. And then all the prolonged hospitalizations, exposures to pain, to medical trauma, situations that kids have been separated from their caregivers, all of this will lead to a higher sensitivity to stress, hypersensitivity to pain, higher autonomic arousal. So, again, the nervous system reacting in much bigger ways and difficulty developing that regulatory capacity to self soothe. So, all these things are biologic factors why kids with congenital heart disease are going to have a harder time with their mental health. But then there's also the psychologically based factors. And so you guys go through hell, like the family factors of socioeconomic hardship. We'll talk a bit more about parental trauma and mental health challenges. And this can affect attachment, increases anxiety in the system, and kids pick up on that, right? There's disruption to normal life. Like the kids are in a sick role when their friends and peers are being quote unquote normal and running around and doing sports. There can be a lot of feelings of powerless and lack of agency that like things happen to these kids. They don't get much control over their lives. There's significant uncertainty and disappointment, and medical trauma that these kids have to go through. There's physical side effects of medications and the medical condition, and physical limitations to activity. Right? They can't do the things that other kids can do. They don't feel good. They have objective physical side effects from things. Limitations to goals. So some kids will feel disabled compared to peers, and that can be really psychologically difficult. And again, decreased independence and autonomy. And that's such a big part of protecting us against anxiety is a sense that we're capable and competent and we can do things and we can positively affect our life and our world. There's lots of anxiety. Kids, again, it's very, very anxiety provoking to be a kid right now in every possible way. But then there's specific anxiety specific to medically complicated kids. So, in addition to all the worries that other kids have about social media and judgment and school and the future and jobs and everything, Medically complex kids also worry about these areas. So, like illness diagnosis anxiety. What will this mean for me? What could happen? Other doctors missing something? What will my treatment be? Will it get worse? The physical integrity for younger kids. Will it hurt? For adolescents, will I look different? Will I be made fun of? Will I be ugly? Will I have a scar? The hospital anxiety. So, like, kids often like things to be routine based and exactly predictable. And these kids are adjusting to multiple transitions, factors outside of their control, fear with medical providers. They can associate doctors and nurses with pain. That can get really scary when the nurses have to come in and do things. Separation from caregivers, alterations in routine. All of that is hugely anxiety provoking for kids. Then the impact of the illness. Will I miss school? Will my friends forget about me? Will my family suffer? Can my family cope? Am I a burden on them? Will we have enough money? Will my parents lose their job? Will I need to depend on my parents for everything all the time? Will I ever get a job? Will someone ever want me? Like, these are big things these kids have to think about and worry about. And then prognosis and death. Some kids worry about this. Will I die? How will my family be without me? Will my siblings be okay? And these are really adult worries that are in these little kids' bodies that they're having to deal with. Has to be said, the parental mental health for kids with cardiac issues is also impacted by all of this. Like, again, I think when I think about, because I think a lot of kids, a lot of patients with many, many, many different medical issues, but the parents that are the most traumatized and affected, I would say, are the ones what you guys gone through, the congenital heart defects, and then oncology parents. And it's just the level of stress and trauma is off the chart. So parents of children with congenital heart defects are at a higher risk of mental health comorbidity. So there's an increased risk of postpartum depression. So in the general population, 10 to 15% for normal population, but up to 40% in the parents of children with congenital heart defects. And this matters because these kids' medical symptoms come up during infancy, right? So at a time where there's so much need, so much fear, and so much anxiety in the system, that affects mental health of parents, which in turn sometimes affects the mental health of kids. And then trauma symptoms are exceptionally high as well, right? So 30% will present with acute stress disorder when kids are in the ICU, up to 30% develop PTSD, 85% show some trauma symptoms, which is basically everyone, right? And then 25 to 50% will show significant signs of clinical depression and anxiety. So, this is to say that the whole family gets affected, but it's important because when we're thinking about mental health in kids and peds, it is affected by parental mental health as well. And so all of this plays a part in why it's harder for these kids. This is just a graph that kind of summarizes what we kind of talked about, but basically, and I'll just kind of go through the blue. Like, you have the prenatal factors, so the in utero environment, the stress that like mom is going through when this is identified in utero. Then the times, the delivery stress, the intensive care stress, the adverse childhood events that can happen. This all affects neurodevelopment and emotional regulation in those early years. There can be brain injury from hypoxia. Again, there's the psychosocial stressors from what all of this does in terms of caregiver strain and financial strain. It's the effect on how they see themselves, their self image, their body image. Am I normal? Am I going to have a future? It affects their education. So many of these kids miss a lot of school, and that can be very difficult. The early peer and social interactions, they may not be able to make friends in the same way because they can't do hockey or run and play. The traumatic healthcare experiences, there often has a lot of traumas associated with this. And this all, contributes to how they cope, what the resilience is. And then this kind of more goes into adulthood, which I won't really address because that's outside of my realm. But basically to say all of these factors are important in understanding how mental health evolves in this population. So that's kind of the specific to cardiac. And then I was gonna kinda get into just general diagnostic categories of anxiety as we understand in psychiatry. Psychiatry has this manual, the Diagnostic Statistical Manual, that basically is a sort of bible for diagnoses. I think it's important to say, at least from my perspective, psychiatric diagnoses are still subjective. Like, these are not objective diagnoses. These DSM diagnoses were made by these are panel of experts who are knowledgeable about this field. They review the research and they try their best to be able to categorize what we see in patients in ways that makes sense. So that if I speak to a psychiatrist, I can say separation anxiety disorder, and they have a sense of what I'm talking about. But psychiatry is very, very subjective. Like, one psychiatrist can see your kid and give a diagnosis, and the other psychiatrist can see it completely different. And so I think, a lot of our patients kind of hold on to the diagnosis, like, I have this, and I have this, and I have this, and I have this, and but they're not really super objective. So take everything with a grain of salt. Um, That said, these are the categories that are in the DSM that I felt were relevant for this talk around anxiety. So I'm going to go through them just kind of briefly and tell you a bit about them and specifically maybe how they are more in medical kids. So, separation anxiety disorder is an excessive or developmentally inappropriate fear and distress around separating from a caregiver or from home. So, there'd be a lot of distress when they think about separating. They may worry about losing a major caregiver or possible harm. Sometimes these kids will be checking in with mom if you're out for dinner. He's supposed to be home at 9. At 9:05, they're calling you. Are you okay? Where are you? Where are you? They can be worried about a bad event that would lead to separation. So they can be worried about like car accidents or kidnapping, things like that. There can be refusal to leave the house because of fear of separation. So this will sometimes lead to school avoidance, particularly if the parents are at home. Um, Reluctance being alone at home without their caregiver. Sometimes refusal to sleep away from caregivers. So I need to be in bed with you or I need to be close to you. Nightmares about separation and a lot of physical symptoms. Like in the real world, this looks like often kids like will be kind of like very clingy, kind of like your shadow. They kind of know need to know where you are at all points in time. You're in the house like, mom, where are you? Like they're just kind of always keeping tabs. On the younger kids, it is much more worries about like, I must be close to mom because something bad's going to happen to her. Then it could be more also, I must be close to mom because what if something bad happens to me? Who's going to help me? But that can lead to a lot of difficulty with separation. And again, just because when kids have spent a lot of time in hospitals, this can be worse because there is a lot of separating you behave from parents. Like, if they need to be hospitalized for a prolonged period of time, but you have siblings, parents can't be there the whole time. And so that can lead to some more separation anxiety symptoms. Social anxiety disorder, so marked fear of embarrassment or humiliation, judgment, negative evaluation in social situations, which is out of proportion to the situation. I think we can all kind of remember times in high school or whatever in our past where we worry about like making mistakes in front of people or saying the wrong thing, but this is above and beyond kind of the normal experience. So these situations will provoke anxiety, which may be expressed as crying or tantrums or freezing, clinging, shrieking, panic, refusal, and they're avoided or endured with distress. So this can lead to a marked impairment in functioning. It's thought to be greater than 6 months. And there's kind of two categories. There's the generalized category, which is the kids that have kind of always been kind of inhibited. They're anxious in many situations. And then there's kind of the non-generalized, which is more like a conditioned response. So this may be someone who fell when they were doing the dance recital, and now they're really fearful of going in front of people because what if I fall? Again, age of onset's around 8 to 15. I'm seeing it in quite young kids, female versus male, which is typical of all anxiety disorders, and it can persist into adulthood. And again, the specific vulnerabilities for social anxiety disorder will be that behaviorally inhibited temperament. So that kind of kid that's kind of cautious at the get-go. If there's social skills deficits, like issues when it comes to speech, that can make them at higher risk of social anxiety. Again, if there was an event where they made a fool of themselves, that often can bring on more social anxiety. And again, going back to the parenting style of overprotectiveness, with basically them not having the ability or the time to be able to make mistakes in front of people, realize it's okay, realize I can manage it. Um, so we see a lot of that. And generalized anxiety disorder, I would say this is what I see the most of now. This is that sort of excessive or uncontrolled worry about a variety of events with the presence of at least one physical symptoms. They can be restless, keyed up, fatigued, it's hard to concentrate, they're irritable, they're tense everywhere, it's hard to fall asleep. I see it as they often experience pathologic doubt, so they have a hard time making even the smallest decisions. They may not even know, like, what ice cream flavor should I get? Is it chocolate? But what if I don't want chocolate? I want vanilla, but maybe vanilla's not the right choice, and maybe it's chocolate. Like, they just really struggle with uncertainty. They want to know exactly what's gonna happen. They want predictability. They want a lot of information, and this is can drive adults crazy because they want, like, to told exactly what's gonna happen, who are we gonna see, all of this stuff. They tend to have more of an attentional bias towards negative or threatening information. So they tend to catastrophize. They expect bad things to happen. They seek excessive reassurance. So a lot of, again, answer my questions, answer my questions. Who's going to be there? Is it going to be okay? They can respond negatively to routine criticism and evaluation, and they often report more intense worries and, again, have that unrealistic negative expectations about the future. Um, which again then leads to a lot of physical complaints. So I call them the "but what if" kids, where they're always being like, "But what if this happens? What if we get there? But what if there's a car accident? But what if this? But what if this? But what if this?" And again, jumping to those worst case scenarios, which leads to them either preparing for the worst case scenario. So some of these kids will tell me, "I have a plan for every possible thing that could ever happen," or some will just be like, "It's going to be awful, so I'm not going to do it." And again, very highly prevalent with medical patients because medical treatment is uncertain and unpredictable. So you have kids that struggle with uncertainty in the most uncertain situation they can be in. And so that can lead to a lot of distress. Obsessive compulsive disorder. Don't see this as much, but definitely I will say it's increasing, and I think we've seen a lot more of this since COVID. But it's the presence of obsessions and compulsions or both that are time consuming and impairing. So obsessions we kind of think of as recurrent, persistent thoughts. They can be urges, images, but they're very distressing, intrusive, and unwanted. And so then the child will attempt to ignore or suppress them through a behavior that's not really realistically linked, but if they don't do it, they feel like if they do it, they feel like their obsession gets better. So, very often obsessions are images, they can be thoughts. They're usually gross to the kid, so they can be sexual or violent. They lead to the patient to question themselves like, am I a good person? Am I a bad person? If I'm having these thoughts, does this mean I actually want to do this? Does this mean I'm not a good person? Does this mean I'm thinking this? So, again, leads to more of this pathologic doubt. And then compulsions are repetitive behaviors or mental acts that are aimed at reducing the anxiety caused by the obsession. So that could be like rituals, it could be tapping things, it could be having things in a certain area or way, it could be checking on things. Common obsessions and compulsions, dirt is a big one, germs, contamination is huge. And again, I think with COVID, that really escalated because we had a whole world of like, don't do that, you'll get sick. And it just kind of like it accelerated some of these things. Sometimes they need to order things. Some people say there are, certain numbers are not okay. They arrange things, they check things. There's a need for symmetry. If I touch it with my left, I have to touch it with the right. They can often have a lot of religious undertones. And sometimes it's called like chasing the just right feeling. So oftentimes, I'll have a compulsion because if I don't do it, something bad's gonna happen, but other times I'll have a compulsion because I just need to have it feel right. And they can't exactly explain to you what that is. They know it when they get there, but they may have to tap things like 15 times until they get it right, and if you interrupt them, they feel wrong, it's distressing, they can't cope, they go back to tapping. I think what the way I see it is what separates OCD from normal thoughts in many ways is the meaning we give to it. So how I say this is that we all have so many ridiculous and nonsense thoughts in our head. They just run through constantly, and we mostly don't pay attention to them. Um, Kids with OCD generally do. So an example I'll give is I'm assuming most of us had it. I definitely had where I'm on the C train and I think, what if I push the person off? I have no intention of pushing the person off. It's just a weird thought, and I go my day. But someone with OCD would be like, oh my God, does that mean I'm going to push them off? Does it mean I'm a bad person because I thought I'm going to push them off? What if I do push them off? What is it going to predict it? I'm not going to go to the C train because I can't put myself in a situation when it's going to happen. So we all have weird thoughts, but kids with OCD give meaning to those thoughts. They think it suggests something. Then it leads to avoidance or stress, and they think about it more, and it becomes a monster instead of just a random thought that we throw away because we all have random thoughts. Illness anxiety disorder, previously known as hypochondriasis, this is when there's excessive worry about the possibility of having or developing a medical condition despite negative testing. I don't see this that honestly, so that much, but I just thought I'd bring it up to it. So these patients pay excessive attention to normal body sensations and misinterpret these sensations as a sign of severe disease. Like, oh, my heart's racing. What if I'm having this? Or I have a headache. I maybe have a brain tumor. The level of anxiety leads to significant distress and functional decline. And so a lot of patients will be engaged in disproportionate or redundant health related behaviors. So I need to go to the doctor, I need to check this out, or I'm checking it again. Is it bigger? Is it smaller? Something's awful's happening. Um, and it can either be separated in care seeking. So I need to go to the doctor, I need the scans, I need more scans, it's not enough, or care avoiding. Something awful's going on. So I'm going to avoid the doctor because I don't want to know about it. And then adjustment disorder. So this is the development of emotional behavioral symptoms in response to an identifiable stressor that occurs within like 3 months of the onset of the stressor. The hard thing about adjustment disorders, it's saying it's above and beyond a normal response, and in some ways, who are we to say what a normal response is? Um, but generally, it's that the symptoms lead to marked distress that's in excess of what would be expected from exposure to that stressor, or it just leads to significant impairment in functioning. And I see a lot of adjustment disorders after kids are diagnosed or something awful has happened. And so, in some ways, it's like, well, of course, this kid is struggling. Who wouldn't? But at the level of symptoms from that struggle is so excessive that it's leading to functional decline, they're withdrawing from school, they're not engaging in life, then we would call it an adjustment disorder because it's really causing significant limitations. They thought is once the stressor has ended, the symptoms do resolve. And an adjustment disorder can be with depressed mood. So kids that are more sad and down. It can be with anxious mood. It can be with anxious and depressed mood. It can be with disturbance in conduct. So if there's more behavioral symptoms in response to that stressor, or mixed disturbances in conduct, anxiety, and depression. So it really can present in many different ways, but it's basically to say that this individual is really struggling to cope with a real stressor, but how they're coping and how their struggle is above and beyond what we would expect, and it's causing significant functional decline. Um, and then trauma. I think trauma is important because it's a big part of what these medical kids have gone through, and it's something to really consider when kids are struggling. So when you think about trauma, there's really kind of two types of trauma. There's like the post-traumatic stress disorder that we hear more about. It's the idea that we have a traumatic reaction to a single episode. So this could be like a time that I'm in the ICU and I thought I was going to die, or something that happened that was awful and scary. Or then there's the complex developmental trauma. So this results from a culmination of traumatic events over the years across people and settings. Generally, when you think about complex developmental trauma, you're thinking about it as like, there's childhood stressors or maybe abuse, neglect in the early environment, things like that. But I actually see this a lot in medical patients. And the reason is that these little kiddos, when they're undergoing a lot of these medical procedures, they don't understand why it's happening. So even though we're having to do these painful and scary things to them to save their lives, to them it can feel very similar. So it can be adults that are coming in and hurting them and they don't understand why, or parents that aren't stopping it. And again, they're not stopping it because we need to save their lives. We understand as adults why this is necessary, but the little kid may not get that. And so what it does lead is to hardwiring of the brain, in that it becomes much more threat focused because the early years have been very scary. So both of these are highly prevalent in medical complex patients. So just specifically going a bit more into like what PTSD is. So generally is exposure to an event. So they'll directly experience it, they'll witness it in person or learn about it, but we're more talking about kids experiencing it here. That can lead to intrusive symptoms. So there may be intense distress or reactivity at exposure to either internal cues or external cues. So it could be a feeling they had that reminded them of a feeling they had before, or it could be like the hospital, driving to the hospital if something scary happened to me there. That can lead to flashbacks where they feel like it's happening again. It can lead to nightmares, dissociative reactions where they feel like they're not there, or panic. And that will then in turn lead to avoidance of either internal experiences or external reminders. So again, I'm not getting close to the hospital. I'm not going there. You can't make me. And then there can be negative cognitive and mood symptoms. So, like forgetting about the event, it didn't happen, I can't remember, I can't tell it to you. Negative beliefs about the self or world, um, disordered beliefs about what happened, making a narrative to the story that doesn't actually make much sense. Persistent negative state. They may lose interest in certain things. I don't want to do anything anymore. They'll sometimes feel like they're more numb and they can't really experience positive emotions. And then also, there may be more hyperarousal symptoms where the nervous system has now dialed up. So they may be more irritable, they can engage in more self-destructive behaviors, hypervigilance, exaggerated startle response, poor concentration, and sleep disturbances. And then there's a complex developmental trauma. So again, in our DSM diagnosis, they don't really acknowledge this. So it comes under a diagnosis of unspecified trauma and other stress-related disorder, which is a real mouthful. But it's basically to say that it occurs when children are exposed to dangers that are unpredictable and uncontrollable. Because the body must allocate resources that are normally for development and growth and focus again on survival. So instead of being calm and regulated, they become more impulsive and reactive to cues. And it basically overloads the kids' ability to cope with emotions. So what we see in these kids is kind of challenges and behaviors across multiple settings. So there could be affect and behavioral dysregulation. So these kids can have extreme responses to minor stressors. The smallest things happens and they flip their lid, they like through the roof. Rapid escalation. So parents will say go from 0 to 100. I don't know what happened. Difficulty self-soothing is really hard for them to bring themselves down. They need the adults to really help them with it. Oftentimes, they'll become more rigid and have a higher need for control. Things have to be exactly their way. They can't be flexible, harder for them to share, harder to see other people's perspectives, and can lead to disturbances in attention and concentration, cognitive and information processing. So again, I spelled that wrong, but executive dysfunction. So kind of most of these kids will develop some ADHD symptoms where they are more impulsive, they are more reactive. It's harder to focus, to stay in the moment. It's harder to stay calm, think about the future. They can have, again, less cognitive flexibility, more ritualistic and rigidity, kind of harder for them to problem solve appropriately. And this can all lead to interpersonal difficulties and attachment issues. So, you know, they can develop this belief the world's a dangerous place, bad things are going to happen, and the adults won't protect me. And this can obviously lead to distrust of medical providers, which is really hard when you're having to bring them back to the hospital for more hospitalizations. And then cognitive distortions, many of them will internalize, it's my fault, I can't trust anyone, I'm a burden, I'm the reason bad things happen, which of course lead to more anxiety and depressive symptoms. And then in terms of like, I thought I'd go a bit into depressive disorders. Um, and I'm only kind of going to focus on really two of them. Um, but like depressive symptoms, so depression again is increasing in children and adolescent like everything. It is also higher in kids with medical conditions, so 11 to 29% compared to 8 to 11, so around double. And it presents differently across the ages. So in preschool kids, you may see more absence of joyful play, more boredom, kind of repetitive play, kind of boring. School age, more irritability, temper tantrums, low frustration tolerance, more physical symptoms. And the adolescents, more low mood, boredom, irritability, changes with sleep, appetite, energy, and suicidality. And again, what we often gets missed is that you don't need to present as sad to be depressed. Adolescents can be irritable and bored, and so sometimes depression does get missed because, well, they're not crying in their bedroom, but they're kind of just irritable and miserable and bored, and nothing gives them any joy, and that also can really speak towards depression. So major depressive disorder. So generally, it's thought these symptoms are going to be most of the day, nearly every day, and it leads to significant symptoms of like distress, highly recurrent, so generally it does, it'll can come back, 26% will recur in 1 to 2 years. It's associated with things like insecure attachment, negative attributional style, impaired self-regulation, poor self-awareness, and insight learned helplessness. So generally kids that will be like, "It's always my fault, I can't do anything right, I can't affect anything anyway," like that kind of sense that I don't have agency over my life are more likely to develop depression. Again, that will also be associated with the greater severity. So having that negative cognitive style, the glass is always half empty. If there's a lot of family distress or dysfunction, exposure to ongoing stressful and traumatic events will all contribute to depression. And so very much linked to also childhood stressors and adversity. An estimated 50% of child onset depression is related to adversity. So it can come out of the blue a lot. Sometimes it does, but very often there's things that are going on in the kid's life that are leading to these depressive symptoms. And then there's also persistent depressive disorder, which is kind of thought to be a bit more of a mild and chronic form of depression, whereas major depressive disorder is thought to be like this acute onset, very intense. This is more kind of like smoldering. Duration is at least a year. So these depressive symptoms, same depressive symptoms, are present most of the day, but instead of nearly every day, it's more days than not. But generally less severe than major depressive disorder. And there's still be those presence of secondary symptoms like changes in appetite, changes in sleep, energy, low self-esteem, poor concentration, and feeling of hopelessness. And so kind of what do you do? How do you get it assessed and how do we treat? The pediatric consultation liaison service. So there's one in children's and there's also one in Edmonton. This is kind of medical psychiatry. And generally, like if you are having concerns about your kids, like this would be the clinic to get connected to. If you're at those two hospitals. So CL is a little bit different than just general psychiatry. Within CL, what we do is we focus on not treating with the patient and their family, but also helping their medical care go smoother, providing support for the medical team and helping build capacity in the system. So there's a consultation aspect, which is typically what we do with you guys, patient-focused evaluations and recommendations, so providing psychiatric assessment, management of physically ill children and adolescents, trying to identify the comorbid conditions that could be at play, identifying the effects of physical illness on mental health, and identifying coping patterns that we could recommend or it could be changed and modifiable. But the other part that we do is liaison. And this is specifically focused on your doctors and the relationship with the patient because doctors are humans, and sometimes they can react poorly to situations, and that can affect how they provide care. Medical system calm down, helping them understand what's going on with their patients and with our patients in the hopes that we can improve care going forward. So there's the patient aspect, but there's also the team aspect. So the assessment of the medical patient is much more complicated than a pure psychiatric interview. And so if you do come and get assessed, there's going to be a lot of different questions that we kind of ask, not only just trying to identify the psychiatric illness, but really understanding how the medical conditions affects them. So when we're doing it, we'll be asking about like the premorbid medical and like the psychiatric functioning, trying to get a sense of like the medical symptoms and burden. So how sick is someone like physically in terms of how it's affecting them, the effects of the medical symptoms on their life and functioning, the meaning they give their experiences, their future, symptoms of medical trauma, the patient and families or siblings' understanding of their medical conditions, diagnosis, and prognosis. Is that in line with the medical team understands? Because that can lead to a lot of conflict. The patient's views of their treatment, their adherence, what do they believe about having to be these medications, their side effects, what have they lost and also gained from their medical condition. And a lot of kids will say, like, I don't like being sick, but look at it, I become more confident. I don't, have to deal with peer pressure. I more have stronger beliefs in myself. I wouldn't change it even if I could. And that's important to understand as well. And that really speaks to resilience in a lot of our kids. The effects of patients' symptoms on their peer relationships, their school, their activities. What is their coping style? So again, are they an active coper or a passive coper? Because that really does affect their resilience, and those are things that are modifiable. The effects of patients' medical symptoms on their family functions. So again, on their parents, on their siblings, on their finances, on their jobs, all of that's like at play. How the family responds to their medical symptoms. So in terms of treatment, so that's kind of how, so basically, if you guys have concerns, if you have access to the CL team, that's the team that is really the one to kind of assess, make recommendations, and kind of be able to give a plan going forward. Basically, when we're thinking about treatment, for mild anxiety, cognitive behavioral therapy has been shown to be effective alone, but for moderate to severe anxiety, combinations of medications and CBT has been shown to be the most effective. And generally, when kids come to me, they're usually quite severe, and so usually I am recommending medications. The first line of treatment is selective serotonin reuptake inhibitors, so SSRIs. So there's quite a few different ones out there. There's ones fluoxetine is also called Prozac, sertraline is called Zoloft, and fluvoxamine is called Luvox, and they have the most evidence in pediatrics. Sertraline is usually the best when you're on other medications, so that's often what I recommend in medically complex kids. We have some other antidepressants, citalopram, also called Celexa, and escitalopram, also called Cipralex, but they're more likely to lead to QTC prolongation, so kind of prolongation of a part of the heart rhythm that places kids at risk of arrhythmias. So generally in the cardiac population, we do try to stay clear of them. And if ineffective, they can't be tolerated. There's other classes of medications, so selective serotonin and norepinephrine reuptake inhibitors. So this could be things like Effexor, Cymbalta. They can be helpful, but they tend to have more side effects. We usually really try to get, if people can respond to SSRIs the first time or second time, that's usually the best. I'll say around 60% of people will respond to SSRIs, the first one that they try. But I always kind of say that means 40% don't. We don't always understand why someone responds to one and not another. So then we'll try a second one. 80% of it will respond to the first or second. So usually we do get a benefit, not with everyone, but usually. But if not, we can try some other strategies. And there are other options if the SSRIs don't work and the SNRIs don't work. Things like pregabalin and Buspar and clonidine, antipsychotics, benzos. There's lots of other things we can try, but they're not really strongly evidence-based. Um, and for some people, they work really well. For others, they don't. So again, the kind of evidence base would say SSRIs. With SSRIs, they can take a while to work. We say around 4 to 6 weeks to see a starting effect, but some people get better after 2 weeks. If it is effective, we don't recommend staying on it forever. We're basically staying around 6 to 12 months. But the idea is that the medications dial down the level of distress the kids experience, making it easier for them to actually do the hard stuff. So engage in therapy, start getting themselves out there, start taking risks and putting themselves in situations where they collect new information to say, actually, I can do this. Actually, it isn't actually so bad. My worst fears aren't valid. And so they kind of are on a different pathway. So you can take away the medications and they can continue in that way. It's like you're at a locked door. Medications unlock the door. So sometimes when people do therapy, but they're so overwhelmingly anxious, it's not going to work. You're like trying to open up a locked door. It gets really frustrating. But if all you do is unlock the door, but you don't walk through it, you're not going to get much better either. So you really, that combination of having the medications to unlock the door, but then therapy to walk through it is really the best approach for helping kids. And goes for either anxiety or depression. It's kind of two sides of the same coin. The medications are the same. The treatment is essentially the same. So that's kind of medications. Um, and then cognitive behavioral therapy. There's many different types of therapies out there. I'm only really focusing on CBT because it's the most evidence-based when it comes to anxiety. But ultimately, having a good relationship with a therapist has been shown to be incredibly effective, regardless of what type of therapy you do. Um, but again, CBT, most evidence-based for anxiety. It's structured, it's manualized. It's based on the premise of that our thoughts and how we approach the world is based on our cognitions, which are often distorted in anxiety and depression. And that in turn affects how we emotionally feel, makes us more anxious or depressed, which in turn affects how we behave. We get more avoidant, we don't leave our bed, we don't do things, which then reinforces our thoughts again. And so CBT focuses on kind of breaking that cycle. So providing psychoeducation on anxiety, identifying and adjusting those cognitive errors that lead us to jump to conclusions that then lead to our behaviors, and supporting the patient in making behavioral changes. So identifying these common cognitive errors, like a lot of things that will kind of lead to anxiety and depression will be these thinking traps that we make, and we all make these. It's just to what extent and how much it affects our functioning. So, like catastrophizing, it's always going to be awful. Why would I do it? I'm going to mess up anyway. It's always bad. No one likes me. No one ever likes me. Mind reading or fortune telling, like I know they think I'm stupid. I know they're laughing at me. I'm not going to go because I know you're going to laugh. So, what's the point? Negating the positive. Yeah, I got, kid gets a 9 out of 10 on an exam, and it's like, instead of focusing on, "Wow, you got 9 right. I'm so bad. I'm so stupid. Why did I get that one wrong? I'm so awful at this. The other ones, I only got them right because they were easy. I was lucky." Those should statements, "I should be fine. I shouldn't cry. I should be perfect. I shouldn't have any feelings. I shouldn't disappoint people." Emotional reasoning. "Well, if I'm feeling anxious, that means something's bad about it, or I feel like an idiot, therefore I must be an idiot." So all those kind of thinking traps of things that we jump to conclusions about is very automatic, but it leads us to feel anxious and depressed, and in turn affects our behaviors, which then reinforces those thoughts. And so one of the most important aspects of treatment is to stop avoiding the things that make you anxious. Again, avoiding things that make you anxious never, ever, ever, ever make your anxiety get better. It makes you feel better because you're not doing what makes you anxious. But if you want to get over that anxious cognition, the anxious situation, it's never going to work. And I mean, there's sometimes that, like, obviously, like, if it's unimportant in your life, don't do it. Like, if you're anxious about sharks, like, there's really no need to put yourself in a situation where you swim with sharks. Like, it's never going to happen in your life. Um, but if you're anxious about school, avoiding school is only gonna make your anxiety worse, and it's only gonna make life harder in the long run, so those are the ones that we really have to get on. So gradual exposure to situations that cause distress. So basically, yeah, we expose kids to situations that cause the distress. You have to experience the distress. You actually have to sit with the distress until it dissipates without rescue behavior. So that's about giving that education, helping them develop active coping strategies so they know I have things to do when I'm experiencing distress, then gradually experiencing that distress, first the easy stuff, then the bigger and bigger one, letting them sit with it and having them realize they got through it. They has the skills, they can do it. Nothing bad happened. Their catastrophizing didn't actually come true. And the next time it gets a little easier and a little easier and a little easier. And then, particularly in pediatric anxiety, families, they're a big part of that. So it's not just individual work, it's family work. And sometimes families don't always understand why they're there, but working with the family to how they respond to the anxiety and to decrease the rescue behaviors is key. And because oftentimes, again, just like my parents did, it makes you feel much better as a parent. It feels like you're helping your kid out. Who wants to force your kids to do things that make them feel awful, right? Because I sure don't. We do it out of love, but it tends to maintain that. And so you need that kind of support from the therapist as well to kind of decrease those behaviors so the kid is able to kind of grow and experience that anxiety in a healthy and safe way. Um, so again, many, many other types of therapies out there. That is one that I say is offered more in Alberta. It's evidence-based. It works really well. It is hard to do. And again, if you're really anxious, doing this for these kids often is too much. And that's where the medications work. They can bring it down so that the kids can be more successful in cognitive behavioral therapy. Because again, you have to be more anxious to get over your anxiety. But if that anxiety is so intolerable, kids will avoid it and not do it. So that's, I think, kind of the major things I wanted to talk about.
Thank you for joining us. If you want to learn more about neurodevelopment and mental health and congenital heart disease, please subscribe to our YouTube channel and follow us on Instagram. We are called Strong Hearts, Growing Minds. In the post section of the YouTube channel, you can also find handouts on various topics, while our Instagram account will keep you updated on new upcoming workshops.